This presentation summarizes and highlights results from a 5-year OCT-based case study of normal tension glaucoma, which included the surprising finding that glaucoma progression, as measured by RNFL loss, had a strong quantifiable relationship to strenuous physical activity, but little to IOP. This presentation's narration has been abbreviated to fit ARVO limitations. See our Central Links site for access to unabbreviated and related presentations as video, slide, or PDF versions. We begin with reviewing the 2017-19 large retinoschisis events that first got our attention, followed by the 2021-23 OCT follow-up study that established the link between strenuous activity and RNFL loss. Some common abbreviations from the eye world used in this presentation. We've also introduced 5 new terms in bold related to the effect of strenuous activity on glaucoma progression. Note we distinguish the commonly measured resting IOP, the target of most glaucoma treatment, from active IOP, which refers to the difficult to measure IOPs experienced during active periods. Also note laminar fluid influx refers to fluid from the lamina corbosa that flows into the prelaminar region, unrelated to the term laminar flow from the physics world. The subject is typical of some NTG patients with myopia, extensive peripapillary atrophy, normal IOP, lowish cerebrospinal fluid pressure, and family history. The subject's history of NTG diagnosis, posterior vitreous detachments, and some retinoschisis are also not unusual. However, things changed dramatically after the fall of 2017, beginning 5 years of bilateral accelerated RNFL loss. So what happened? Several days of very strenuous activity while installing a sprinkler system triggered major right eye retinoschisis that eventually threatened central vision, followed by significant RNFL loss. The global RNFL loss rate of 4 micrometers per year during the lengthy retinoschisis was quite high compared to typical less than 1 micrometer per year loss for healthy subjects. Weekly OCTs were obtained and analyzed throughout most of this period in an attempt to understand and ultimately control what was happening. So what did we learn during this initial study? Both eyes experienced major retinoschisis, with fluid 1 originating from the inferotemporal LC moving into inner and outer retina in direction of macula. Inner retina fluid 2 was associated with RNFL loss, but outer retina fluid 3 was not. However, some RNFL loss also occurred in areas without obvious fluid influx 4. Raising IOP, lowering IOP, and Avastin had little effect on fluid influx rate, suggesting a non-neovascular source of fluid not influenced by modest changes to IOP. On the other hand, during maximum right eye fluid influx, after an overnight drop in IOP from 18 to 12, FA revealed fluorescence at influx site 1, indicating a vascular origin 5, suggesting the simple hypothesis that physical activity leads to vessel leaks and subsequent RNFL loss, but with varying fluid accumulation. Left eye confirmed all right eye observations. In this case, major left eye retinoschisis resulted from strenuous lawn dethatching, followed by head-down back stretching to address backache, creating venous pressure and active IOP spikes, 6, plus NSAID use, increasing bleeding risk, 7, all suggesting again a vascular hypothesis for influx. Question, can this system be managed to minimize RNFL loss? What exactly needs to be monitored and controlled? We propose studying this system more closely with frequent high-res OCT scans to help clarify cause and effect, but first needed to address a few technical issues. The Heidelberg Spectralis was the only OCT machine available to us that could be used to precisely measure RNFL and retinal thickness. However, its built-in algorithmic support for such measurements was too imprecise for our purposes. This led us to rely on use of its manual measurement tools, combined with special attention to proper scan positioning to make very precise measurements, examples of which are shown. Most importantly, small changes to site-specific RNFL thickness could be reliably measured over time compared to the noisier built-in support. Next, since fluid accumulation and RNFL loss tended to be localized between major retinal blood vessels, and major blood vessels interfered with making direct, precise RNFL measurements, we adopted a simplified sector numbering scheme based on vessel pairs for the superior temporal inferior sectors where most RNFL is lost and is best visualized with OCT. This numbering scheme was used to specify locations throughout the optic nerve head and bordering RNFL and choroid. For the follow-up study, we chose a set of scan types, weekly high-res optic nerve head and triplicate RNFL circle OCT scans that supported close monitoring of changes to fluid accumulation and RNFL thickness. Our expectation was that fluid changes being related to vessel leakage would be predictive of RNFL loss, with fluid at specific sites acting as canaries. Canaries would then be associated with specific activities, revealing more about the causal chain activity to fluid to RNFL loss. But things turned out to be much simpler than that. So what did we find? During the 2021 to 23 study period, RNFL loss was about half that compared to the period with major retinoschisis, but still high compared to healthy subjects. The plot shows mean bilateral global RNFL thickness, the average of all 20 sectors. Loss was sector-specific and often associated with laminar fluid influx. Losses were discontinuous, occurring in roughly 8-week blocks, and initiated by one or more non-resting IOP factors. So what were the non-resting IOP factors initiating RNFL loss? The non-IOP factor initiating RNFL loss appears to be multi-day clusters of strenuous activity, date and duration of which are shown by the vertical red dotted lines in the plot. Each cluster's total micrometer loss was the sum of sector losses during the 8 weeks following the cluster, where dividing by 20, the total sector number gives global loss. Note clusters B, C, D, E were considered together since their 8-week RNFL loss periods overlapped. To review, clusters of relatively ordinary activity drove subsequent RNFL loss, taking about 8 weeks to complete, raising the question of what characteristics of these clusters determined their impact on RNFL loss. Strenuous activity time and intensity were obvious factors to consider. The simplest approach giving the most consistent results for RNFL loss was that shown, where a strenuous activity time, SAT, was defined as the product of activity time and intensity, with intensity corresponding roughly to the low, moderate, vigorous levels described by others. In addition, extra intensity was assigned to activities involving some head-down posture and to those performed at high temperature or humidity. The SAT for a cluster, then, was the sum of the individual SATs accumulated during the duration of the cluster, ended by many days of more sedentary behavior. So how did RNFL loss vary with cluster SAT? RNFL loss appears to be a surprisingly simple function of strenuous activity time. To summarize how we got here, precise RNFL measurements across 20 sectors, both eyes, over long time periods for many different clusters with varying activity types revealed a simple relationship. In other words, we had to take a lot of measurements under varying conditions to average out the noise in the system to see this underlying simplicity. So what mathematical function best fits this relationship? The relationship of RNFL loss to SAT had 3 key features. 1, a rapid rise in RNFL loss with SAT. 2, a maximum SAT sub m below which RNFL loss is considered tolerable. And 3, a possible small background RNFL loss rate, K0, when fully sedentary. The simplest good fit was a third-order power function with strenuous activity coefficient, KSA, equal to the slope of micrometer loss versus SAT cube plot, and a possible small background loss rate, K0, equal to the intercept. Note that various types of estimation are greatly facilitated by such a simple relationship. For example, even without knowing anything about KSA, compared to a SAT of 1 hour, 2 hours was about 2 to the third or 8 times, and 3 hours was about 27 times riskier than 1 hour. In general, breaking strenuous activity into smaller isolated times greatly reduced RNFL loss, whereas combining activities into larger clusters greatly increased RNFL loss. A model based only on cluster SATs, KSA, and an 8-week RNFL loss period produced an excellent fit to bilateral global RNFL measurements during 2021 and 23. A slightly better fit was obtained using 0.6 micrometers for K0, the background loss rate when sedentary. However, this small K0 is equivalent to just 0.2 micrometers per year global RNFL loss, which is easily accounted for by just 1.3 hours of strenuous activity time per week. In other words, the apparent background rate was most likely just an artifact of our not counting the small effect of strenuous activity times between clusters, implying K0 is about 0, with strenuous activity time accounting for all RNFL loss in this subject, and meaning that while there's no free pass for small sats, there's probably also no other process needing treatment beyond that tied to strenuous activity effects. So what's the link between this simple model of the 2021 to 23 data and the 2018 to 19 retinoschisis events? Is there a single simple mechanism that can tie all this together? This slide reviews the evidence previously presented for vessel leakage being the underlying mechanism for fluid influx, retinoschisis, and RNFL loss in this subject. Strenuous activity appears to increase risk of such leakage, although its effect varied from being minor to major, depending on activity length, intensity, and clustering, and where runaway refers to a vessel leak made so large that it creates a large pocket of adjacent fluid, retinoschisis, being absorbed by surrounding tissue, which reduces fluid pressure outside the leak, likely increasing vessel leakage and susceptibility to strenuous activity, making RNFL loss less predictable. With respect to clustering, note that activities with a modest strenuous activity time might be relatively harmless in isolation, with leakage receding over a few days, but produce significant RNFL loss if repeated several times in 1 week, with each modest activity increasing total leak volume and subsequent RNFL loss. Finally, the very rapid increase of RNFL loss with SAT cubed may simply be due to larger vessel breaks, both leaking at a faster rate and staying open longer, producing much larger leak volumes. This slide reviews the key findings from our 2021 to 23 study. For this subject, glaucoma progression as measured by RNFL loss was mainly driven by clusters of strenuous activity, the total time and intensity of which had a strong, well-defined relationship to RNFL loss, where it took about 8 weeks after each cluster for RNFL loss to complete, and where the strenuous activity coefficient, KSA, likely varies with glaucoma type, stage, history, and subject. There was no evidence for any RNFL reducing process other than that related to strenuous activity, progression being minimized by simply keeping weekly strenuous activity time below the level at which calculated loss was considered tolerable. Note, however, that other factors related to this process, such as those affecting vessel leakage, may affect the likelihood of triggering RNFL loss by strenuous activity. Finally, IOP in the range of 12 to 18 appeared unrelated to RNFL loss. However, IOPs greater than 18 were part of the earlier history of this subject, possibly helping to create the conditions driving the current relationship of activity to RNFL loss. Also, IOPs less than 12 might be protective by improving ocular blood flow and reducing LC stress, but offset by any increased vessel leakage at lower IOP, making it unclear what net effect keeping IOP below 12 might have for this subject. So why has this simple relationship between activity and RNFL loss remained largely hidden? First, varying KSAs, the need to consider clusters, the cubic function itself, and the 8-week delay in RNFL loss all add to confusion, obscuring the relationship between RNFL loss and strenuous activity. Second, it's technically difficult to accurately measure small RNFL changes relative to associated strenuous activities. And third, there's an understandable reluctance by many to consider moderate strenuous activity as potentially harmful. Given all these considerations, it may well be that strenuous activity plays a larger role in other glaucoma cases than common wisdom or current practice would suggest. For this subject in particular, physical activity clearly trumped IOP, and progression was minimized with easily adopted behavior changes.